Good afternoon. My name is Vincent Cheng, and I'm a fourth-year general surgery resident at USC. Today, I'll be presenting a project that quantifies recent trends and compares clinical outcomes in the management of acute cholecystitis during pregnancy. None of the authors involved in this study have any conflicts of interest or disclosures to inform. Nearly 30 years ago, the NIH strongly recommended against cholecystectomy in the treatment of pregnant women with acute cholecystitis. While SAGE's recommendation in 1998 were a bit more open to the idea of cholecystectomy during the second trimester, it was clearly not considered the ideal treatment. It really wasn't until 2007 when SAGE's formally revised its guidelines and encouraged laparoscopic cholecystectomy regardless of trimester. Now, despite the persistence of this recommendation for the next 10 years, SAGES still considers this evidence supporting this guideline as weak and of low quality. And it's true. Most of the evidence comes from single-center studies with small sample sizes, and they treat the entire spectrum of gallbladder disease as one pathology. As a result, the purpose of our study was to focus on acute cholecystitis, quantify the impact of SAGES' change in recommendation, and compare clinical outcomes of operative and non-operative management during pregnancy. To do this, we conducted a retrospective analysis of the national inpatient sample, which contains data for over 7 million hospital stays each year and serves as a nationally representative sample. We queried the database for all pregnant women, and we excluded all abnormal pregnancies. We included only patients with acute cholecystitis and segregated them into 3 groups based on management. Non-operative management is represented by dark blue, laparoscopic cholecystectomy is represented with gold, and open cholecystectomy is represented by light blue. Now, throughout the entire presentation, these 3 colors will remain consistent. Overall, the baseline patient characteristics were very similar across the 3 groups, but we do want to point out 3 main differences. Patients who underwent laparoscopic cholecystectomy were more likely to have private insurance and have higher income. Furthermore, patients who underwent laparoscopic cholecystectomy were more likely to be white. Now on this slide, we've illustrated the proportion of each management style by year. Keep in mind that 2007 is when SAGES first started pushing for laparoscopic cholecystectomy, and since this time, this group, as represented by gold, seems to be growing compared to the other groups. When we dichotomize the years into pre-2007 and post-2007, we found a statistically significant increase in the rate of laparoscopic cholecystectomy after 2007. Furthermore, of patients undergoing laparoscopic cholecystectomy, the days to surgery was significantly shorter. In other words, non-operative management was used less frequently and trialed for a shorter period of time after 2007 when SAGES revised its recommendation. This slide represents the results of multivariate logistic regression. The x-axis represents the odds ratio. The dotted line at 1 represents the baseline patient characteristic of non-operative management. The golden triangle represents laparoscopic cholecystectomy, and the blue circle represents open cholecystectomy. The error bars represent 95% confidence intervals. We can see that laparoscopic cholecystectomy was significantly associated with lower rates of preterm labor, delivery, or abortion. Open cholecystectomy, on the other hand, was associated with significantly higher rates. Laparoscopic cholecystectomy was also associated with lower rates of antepartum hemorrhage and lower rates of amniotic infection. There were no differences in mortality rates. This slide shows the impact of delay to cholecystectomy. On the x-axis is the number of days from admission to operative management. The longer the delay to laparoscopic cholecystectomy, the higher the rate of complications. And this was confirmed with multivariate regression as well, as shown in the figure legend. This slide illustrates the results of multivariate linear regression. The y-axis represents the regression coefficient. We can see that both types of operative intervention were significantly associated with longer hospital stay and greater hospital charges. However, when compared to open cholecystectomy, laparoscopic cholecystectomy was associated with shorter stays and lower costs. In conclusion, laparoscopic cholecystectomy has become more popular after SAGES began encouraging it in 2007. In other words, SAGES had a positive impact on the rates of laparoscopic cholecystectomy during pregnancy. Furthermore, laparoscopic cholecystectomy is significantly associated with improved clinical outcomes in pregnant women with acute cholecystitis. Longer delays to cholecystectomy were associated with higher rates of complications. Thank you very much for your time and the opportunity to present this study.